Well, we have a lot to cover this evening, so we'll start now. It's wonderful to have you all there. Thank you for joining. This is AONM's webinar on Can Infections Really Trigger Neuropsychiatric Disorders with Professor Shimasaki from Moleculera in Oklahoma, who we're delighted to welcome today. I'll just introduce him briefly. Professor Shimasaki is co-founder and CEO of Moleculera Labs, a immunology precision medicine company focusing on diagnosing neurological, psychiatric, and behavioral disorders triggered by an autoimmune response. As a scientist, business person, and serial entrepreneur, his work spans all stages of research and development. Professor Shimasaki received his BS in biochemistry from the University of California at Davis, his PhD in molecular biology from the University of Tulsa, and his MBA from Northwestern University, Kellogg School of Business. He's an adjunct professor and senior entrepreneur in residence at the University of Oklahoma, and teaches biotechnology entrepreneurship. His passion is to help translate scientific and medical discoveries into acutely needed products so that more patients can live healthier lives. So I'd just like to remind you that you're very welcome to put your questions into the Q&A. That's preferable to the chat, please, because then we can also record it for any questions that we haven't yet managed to answer. And we'll have a good period of time at the end for questions. So Professor Shimasaki, thank you so much, and over to you.
Thank you, Jillian, and thank you, AONM. We look forward to answering any questions about this topic, but it's an exciting area of medicine, an emerging area of medicine. And with the hour that we have here, what I'll try to do is go through the biology, the clinical manifestations, a little bit of the science, the history, and then how the panel, what we call the Cunningham Panel, can help and aid in the diagnosis and therapy. So I'm trusting, can you see my slides well? All right. Hearing none, I'm presuming
yes,
that's
can do. Thank you.
All right, very good.
Yeah.
Thank you. Okay, so the title of my talk today is Can Infections Really Trigger Neuropsychiatric Disorders? And it's an important question. And this is really about the biological basis of the targets that I'm going to talk about in the panel. It's something that's been in research for about 30 years and about 10 years since we have launched this and done clinical testing. And we have about 13,000 patients we've tested to date. So with that, let me give a disclosure. I am co-founder, as was mentioned, CEO of Moleculera Labs. We perform the Cunningham Panel, but any testing data that I'm going to share with you today is going to be from either peer-reviewed published journal articles or research that's current. And as a general disclaimer, this content is made for informational purposes only. It's not intended to diagnose or provide healthcare advice for any particular or individual medical situation. And so we recommend you consult your healthcare provider for those questions. So what I want to cover today is the challenges in the diagnosis of these neurologic, psychiatric, and behavioral disorders. And then why do certain infections tend to be identified in patients that have these autoimmune neurologic and psychiatric disorders? Some of these we'll briefly talk about, such as PANDAS and PANS. You may have been familiar with that, or neurologic Lyme, and now even we'll briefly touch on what we know as long COVID. And then I'll move over to how the targets that are in the panel that we call the Cunningham Panel can be utilized to diagnose and direct therapy for patients with these immune-mediated neuropsychiatric disorders that are triggered by infections. And then I'll briefly cover some of the general therapeutic modalities that have been shown to be clinically effective in treating these patients that have autoimmune encephalopathy secondary to infectious disease. So let's get started. There are almost 800 million individuals in the world that have some type of psychiatric, neurologic, or behavioral disorders. And you can see these here from autism to schizophrenia, bipolar, epilepsy, Tourette's, PANDAS and PANS, etc. So what do these all have in common? Well, one of the things that they have in common is that these are all diagnosed by symptoms rather than etiology. So for instance, if a patient has tics, well, motor tics or vocal tics for more than 12 months, by definition, the patient can be diagnosed with Tourette syndrome. If you see maybe patients with repetitive behavior, hyperactivity, irritability, separation anxiety, there's a possibility they could be diagnosed with ADHD. And the list goes on. These are just a handful of symptoms and a handful of diagnoses. But the point is that these conditions are diagnosed by symptoms, but not the underlying root cause. And then the standard of care for various neuropsychiatric and behavioral disorders focuses on treating the symptoms and coping. And these include various psychotropic drugs, of which they have been very helpful over the years since they've been developed. But they're also being used to treat symptoms that have actually a different etiology, which we'll talk about. Psychotherapy is also one of the modalities, cognitive behavioral therapy, and then also institutionalization. And so many of these psychiatric medications, as you can see here, this is older data, but tens of millions of individuals are on them, but also many of them contain these black box warnings. The FDA cautions individuals because of the suicidal ideation that comes with this. So what I want to share throughout this talk is that there's a complex interaction between infections, the immune system, and the brain. And what we see is that various infectious triggers, bacteria, virus, parasites, fungal infections, environmental, interact in a way that in the body stimulate the immune system, whether it's autoimmune antibodies, inflammation, microglia, activation, cytokines, et cetera, and then interfere with brain function. This happens in the context of a genetic predisposition, not to neuropsychiatric disorders, but to immune system dysfunction. So this is going to be the basis of what we're going to cover today. I want to share with you a couple of stories. An example, you might have read about this, a New York Times story, but also a publication about an individual in Japan whom his doctor was a psychiatrist and diagnosed him as paranoid schizophrenia. After prescribing a series of antipsychotic drugs, his symptoms were then deemed to be treatment resistant. In other words, none of the treatments that they gave him were actually helpful in ameliorating his symptoms. Interestingly, about a year later, he developed acute myeloid leukemia or cancer and needed a bone marrow transplant. And after the procedure, his schizophrenia seemingly vanished. And the comment was, he's completely off all medication and shows no sign of psychiatric symptoms. And somehow the transplant cured the man's schizophrenia. Well, a little perplexing to figure that out. There's also a publication in Frontiers in Psychiatry on this particular patient. And it shows that his level of what's called PASS, which is actually a positive and negative syndrome scale for schizophrenia. You can see at the time of bone marrow transplant, it dropped really down to almost baseline in this case. And so what happened really with a bone marrow transplant that actually caused them to say that this actually cured his schizophrenia? Another such example of Susanna Kalayan, which is known as from the book that she wrote called Brain on Fire. She is and used to be a New York Post journalist. She suddenly developed these really strange symptoms of psychosis, violence, and instability, and they actually hospitalized her because of these severe symptoms. She also lost consciousness, had seizures, memory loss. And the idea was that there must be some type of either psychotic disorder, schizophrenia, bipolar, because all of her quote unquote laboratory tests came back normal. She wrote the book called Brain on Fire, which is something that if you haven't read, it'd be an interesting read. As with all good books, sometimes they get made into movies. So Brain on Fire is also in a movie. But what she had was NMDA receptor encephalitis, which is an infection-triggered autoimmune condition that targets receptors in the brain. So in journals, we can find that there's a growing publication list, almost an explosion, of the connection between infections and autoimmune dysfunction and neuropsychiatric disorders. This is one such study that was published in JAMA Psychiatry. And what we find is that it was based on over 1 million individuals that were followed from birth to age 18. And what they found by doing this epidemiological study, they found that if a patient was hospitalized for a severe infection, that the risk of developing mental disorders increased by more than 80% for a diagnosis of schizophrenia, autism, ADD, ADHD, obsessive compulsive disorder, etc. So in an editorial, the authors described how could exposure to infections affect the brain mechanistically to give rise to mental disorders. Comment was circulating autoantibodies that enter the brain via compromised blood-brain barrier, bind to neurotransmitter receptors, and is a potential explanation. And this mechanism has been proposed in PANDAS and other mental disorders. Well, NMDA receptor encephalitis is also just exactly what they're describing here, circulating autoantibodies into the brain and bind to neurotransmitter receptors. But that condition is rather rare. What we're talking about really are other conditions that are not rare. And so how does this occur biologically? Well, we know that we have infections with bacteria and virus, and then our body makes antibodies. And we're all familiar with antibodies because it is really the protective barrier that is being looked at as far as when we look at SARS-CoV-2 and other types of infections. Wherein in these patients, the antibodies that they generate actually cross-react with neurologic receptors in the brain and through a mechanism we call molecular mimicry. And then they interfere with the brain function once they cross the blood-brain barrier, which produces these neuropsychiatric symptoms, which can be heterogeneous. Anxiety, aggression, rage, the list goes on. And as you saw with the other couple of examples, they could be sometimes very severe. Typically, patients will be placed, as mentioned, for symptomatic treatment on neuropsychiatric drugs. In the cases where this is the standard of care for those with traditional psychiatric symptoms, these can be quite effective. But in cases where these are not, and they're actually an underlying infection-triggered autoimmune condition, they are not effective. Interestingly now, what we see is this new infection, or we'll call this new after a couple of years, SARS-CoV-2, triggering what we now know as long COVID, autoimmune neuropsychiatric symptoms, myocarditis, cardiovascular disorders, chronic fatigue-like syndromes, etc. And you have within your own country there a very prominent neuroscientist and neuropsychiatrist, Edward Bullmore. So Professor Bullmore wrote The Inflamed Mind, which is a very good read if you haven't read that. He's also the head of the Department of Psychiatry at Cambridge University. And he outlines that this connection between depression and inflammation in the brain, very similar to what we've described here. And he provides the persuasive link between inflammation and depression. Other articles that you can look through and pick up journals now and look through, and this one in Frontiers in Psychiatry, showing that this interconnection between infections, neuronal antibodies, which we're going to talk about, these are the ones that we measure in the Cunningham Panel, and psychiatric and psychotic disorders. But you can also see the involvement with the immune system, autoimmune disease, the microbiome, and other types of conditions. So this connection, though complex, exists. And one thing that's interesting is infection-triggered neuropsychiatric disorders are not new. So this is in the 1800s, Sir William Osler described what he called these bizarre and percipitive behaviors in children with what he called chorea minor, or these OCD-like symptoms in Sydenham chorea. Well, we know that group A strep or streptococcal infection, when triggered to cause these antibodies that attack the heart valve, is diagnosed and described as rheumatic fever. Well, Sydenham chorea is the neurologic manifestation of rheumatic fever. And this is the case where these antibodies actually began to attack parts of the brain called the basal ganglia. And Sydenham chorea, when first described, was also known as St. Vitus's dance. And it was characterized by these abnormal movements, the loss of fine motor control, and the loss of emotional control. So what we're left with is an unintended segmentation and a medical challenge in the care of patients with neurologic, psychiatric, and behavioral disorders. Today, psychiatry is practiced separately from immunology, which is practiced separately from neurology and infectious disease. Whereas what we do know is infectious diseases actually impact psychiatry, as was mentioned, and neurology, and also immunology. And so these integrated components of disease biology is the way in which we can better care for and accelerate the diagnosis and treatment of patients with these autoimmune neuropsychiatric disorders. So this cartoon kind of depicts really the status, and it's in for patients and physicians that are dealing with autoimmune neuropsychiatric disorders, is that we're taught not to think outside of the box. And this is the case. In fact, we've got studies where we show that on average, these patients that come to us may have seen between 5 and 15 doctors prior to getting a proper diagnosis. The good news is that we see some amazing patient recoveries when they're properly diagnosed and treated. This is Adam. His mother sent us this picture, and actually there was a story published about him. He was diagnosed with ADHD. They thought he also had autism. They were resolved to begin to put him into an institution because they weren't unable to take care of him. They found out about the testing that we did, and we tested him. He was positive. He received proper treatment and is now completely well. In fact, he's now grown up in high school, and his mother sent us this picture of him running cross country. He said, recovery is possible. He's 10,000 times better. So why do certain infections tend to be identified in patients with these autoimmune neurologic and psychiatric disorders, such as PANDAS, PANS, what we call neurologic Lyme or post-treatment Lyme disorder, and even long COVID? Well, there are certain infections that seem to be more frequently associated with these autoimmune encephalopathies. I mentioned strep. We see it in Sydenham chorea. PANDAS is really the S in PANDAS stands for strep infection. Influenza, we see that too. Varicella, Mycoplasma, Lyme, Babesia, Bartonella, Coxsackie virus. These tend to be more frequently associated. Now, it doesn't mean that everybody who gets these infections will get these neuropsychiatric disorders. In fact, the majority of people do not. It's the population of individuals that have this genetic predisposition to immune dysregulation, and we'll talk a little bit more about that. What we do know, as I mentioned, the SARS-CoV-2 virus is actually also included now in the sense that it creates these autoimmune and anti-neuronal antibodies, but also those that are directed against other parts of the body, including cardiovascular and kidney and other parts. So what is PANDAS? Briefly, I just want to share about what the syndrome is and how it actually is not only a syndrome that's very helpful to understand, but it's also can be a medical model for other types of disorders. So by definition, it's pediatric autoimmune neuropsychiatric disorder associated with a streptococcal infection. And so it was described by Dr. Susan Swedo at the National Institutes of Mental Health back in the late 90s. And this was published on the first 50 cases. In fact, they described that they had multiple other cases with other infections other than strep that triggered these sudden onset of OCD, but they wanted to study a homogeneous population. So what is the diagnostic criteria for PANDAS or PANS? It's believed that 1 out of 150 to 200 children have PANDAS or PANS. It's diagnosed by symptoms. So it is not, again, like other disorders I mentioned, it is a symptom diagnosis. It is based on a clinical diagnosis by a physician or a clinician. And it's the presence of obsessive compulsive disorders or tic disorder for PANDAS, prepubertal onset, meaning again, a pediatric, acute symptom onset, meaning sudden onset within, often described as within 24, 48 hours or slightly more, and an association with group A strep and associated with neurologic abnormalities. PANS, on the other hand, which is a broader criteria, which I'll describe here in just a second a little more. The criteria is very similar, but instead of tics, it's abrupt dramatic OCD onset or severely restricted food intake. And again, these types of food intake restrictions are more fear of food contamination or fear of choking. The continual presence of additional neuropsychiatric symptoms, and then there's the list here: anxiety, irritability, sensory or motor abnormalities, and symptoms that are not better explained by other neurologic or medical disorders, such as Sydenham chorea or lupus or other. So how are all these conditions connected? And some of this has to be helpful with the understanding of the nomenclature. So PANDAS, as I mentioned, pediatric autoimmune neuropsychiatric disorder associated with a strep infection. There are also other microbes, as I mentioned, that are not strep that do trigger and cause these infection-triggered autoimmune conditions. And it's believed that there are environmental factors or other biological factors. So these two are comprised of both infectious and non-infectious triggers, and that's where the term PANS came up: pediatric acute onset neuropsychiatric syndromes. So PANDAS is a subset of PANS and other infections from Lyme, Babesia, Bartonella. But again, this is categorized by pediatric and acute onset. There's other groups that have named a term called ANDL. In fact, in the Lyme community, they see many of these post-treatment Lyme and neurologic Lyme, in which we also find these autoimmune antibodies present. ANDL can also be thought of in their cases as adult neuropsychiatric disorder associated with Lyme. And what we find that broader terminology describing the conditions such as autoimmune encephalopathy secondary to infection, or basal ganglia encephalitis, meaning the portion of the brain in which the antibodies are actually attacking, such as in Sydenham chorea. So these you'll see more descriptive of these broader terms, because remember, PANDAS is pediatric, and then it's limited to strep. So you'll see more of these terminology become more common. And then, as I mentioned, autoimmune encephalitis or encephalopathy, some of this has to do with also connotation versus denotation. The denotation for encephalitis is just the brain and inflammation, or inflammation of the brain. However, encephalitis is always or typically thought of as direct effect of a pathogen on the brain, like viral or bacterial or fungal, which are rather rare, but they do occur. So the term encephalitis sometimes can be used in connection or connotation with that. Whereas we're referring to these autoimmune encephalitis or autoimmune encephalopathy. When we say encephalopathy, we're referring then to brain and any disorder or disease of the brain, which might make other people feel a little bit better about calling it an autoimmune encephalopathy. But again, it can be an infectious trigger or a non-infectious trigger. And we also know, as mentioned with the schizophrenia and the cancer neoplasm, that various neoplasms can trigger these autoimmune antibodies to begin attacking the brain. such as we saw with the patient in Japan that was diagnosed with schizophrenia and lost his diagnosis after being treated with a bone marrow transplant. Then the infectious triggers can be, as I mentioned, Lyme, strep, mycoplasma, babesia, Bartonella, and others. So what we're going to be really referring to and talking to is the autoimmune encephalitis or autoimmune encephalopathy secondary to these infectious agents, which we believe are fairly actually predominantly seen in many patients that might be diagnosed with these traditional neurologic, psychiatric, and behavioral disorders. So remember this pictorial graph. We talked about the infection leading to antibodies to those that cross-react with nerves or receptors in the brain, creating these neuropsychiatric conditions. We're going to focus here on this part of the process, the microbial and the infection producing antibodies, because we really want to understand what really is a trigger and why do not all people who get strep or Lyme or babesia end up with neuropsychiatric disorders. Well, various infections and our bodies share similar protein sequences. So when the protein sequence is the same in a certain part of a bacteria to a part of our body, we call these common epitopes. So when an antibody is made against the bacteria and a particular epitope that, let's say, is common to a nerve or a nerve fiber or some part of a receptor in the brain, these epitopes are common epitopes. But when an antibody is made to that part of the bacteria or virus or fungal infection, it will naturally cross-react with the same target that it looks like is either identical or very similar to, which is what we call molecular mimicry or autoimmune disease. So molecular mimicry and the autoimmune disorders can be thought of as what we think of as friendly fire in the wartime. So typically it's where our most powerful troops are misdirected against our own troops, not realizing that it can't distinguish between our own troops and the enemy. Interestingly, a family history of autoimmune dysfunction is often identified in patients with these infection-triggered autoimmune neuropsychiatric disorders. And then we won't go into this, but genetic factors are also identified that play a role. The MHC complexes and the HLA class 1 and class 2, which are the proteins in the part of our immune system that regulates self, non-self discrimination. So molecular mimicry can occur between strep and self-antigen. So this is the bacterial organism of strep. On its surface, it has these carbohydrates and also what's called an M protein. There's literally 80 to 100 or more of these different types of proteins, M proteins in different types, and certain ones end up with common sequence homology to parts of our body. In the case that I mentioned for rheumatic fever, acute rheumatic fever, there's some commonality between proteins in the heart valve, which then creates acute rheumatic fever. But we also know that it also ends up with basal ganglia antibodies, which is then diagnosed as Sydenham's chorea. But other conditions occur: arthralgia, joint pain, kidney. And interestingly, in Lyme and post-treatment Lyme disease, where you're going to hear some talks and have heard talks about, in those cases where you have post-treatment Lyme disease or what might be referred to as neurologic Lyme, you see that also within Borrelia burgdorferi, there is a particular outer surface protein A that has a sequence homology in common to very similar parts of the body that I described that strep identifies. And so you see the symptoms of Lyme neuroborreliosis, similar types of symptoms, brain fog, anxiety, lightheadedness, heart conditions, POTS, postural orthostatic tachycardia syndrome, which again is an autoimmune condition, and various types of arthralgia and pain. And now we see that published reports show that 1 in 3 COVID-19 patients are diagnosed with some neuropsychiatric condition over the next 6 months. Again, because so many people have been infected, that even a small percentage or portion of individuals that have these non-self dysregulation then triggered by an infection can end up with these types of conditions. So it's been described as long COVID, but long COVID has some very similar symptoms to myalgic encephalomyelitis and chronic fatigue syndrome. And you can see very similar types of conditions. And again, there's been at least literature and research showing that there's a connection to an infection, or at least the onset of infection. So now, how did the targets in the Cunningham panel, how can they be utilized so that you can help diagnose and direct therapy to patients that might have these immune-mediated neuropsychiatric disorders? Well, as I mentioned, autoimmune encephalitis or encephalopathy or basal ganglia encephalitis, which the Cunningham panel is useful in identifying. This is the process. AONM, who is the one who will handle all of that in the UK for us and neighboring countries in Europe. They will then have the blood collected and sent over to us in the US as expeditiously as possible. And then once it arrives in our CLIA certified lab, it's a high complexity lab that has been inspected 7 times with no deficiencies. We test for 4 different brain targets and antibodies directed against those targets, and 1 neuronal cell stimulatory assay, which we call CAM kinase. I'll talk about that in just a second. The turnaround time is anywhere from 2 to 3 weeks, depending upon volume. And then it's reviewed and notification is sent to AONM. The report is then uploaded, and then they will then send that back to the clinician or the caregiver for that report. Out of the 13,000 patients that we have tested so far, there are some commonalities that we see in patients who test positive for what we'll say these anti-neuronal antibodies for autoimmune encephalopathy and basal ganglia encephalitis. They tend to have sudden onset of neuropsychiatric or behavioral symptoms. They also can be treatment resistant to standard neuropsychiatric drugs, as was mentioned with the other case with the neoplasm associated schizophrenia. The symptoms can wax and wane. You may see dilated pupils. You might see urinary frequency in older children. You may see regression to bedwetting. They may be associated with multiple or post-infections, meaning that they might have had prior infections or multiple infections, or they've known to have multiple infections. And they may even have, as mentioned, an autoimmune disorder family history, where there's various types of autoimmune disorders, such as whether it's lupus, even asthma, other types of even diabetes type 1, psoriasis, any kind of autoimmune disorder which identifies that there may be some immune dysfunction. Sudden onset of OCD is also another one that does come up. Anxiety, rage, separation anxiety. And this one, which is more troubling, is the suicidal ideation. Although it may not be discussed verbally in normal situations, many of our physicians say that if you actually sit down and ask them, have you had suicidal thoughts? Most often the answer is yes. They may have a PANDAS PANS diagnosis, or they might have neurologic Lyme diagnosis. So these are just a handful of different types of commonalities we see. They don't have to have all of them, but there are things that seem to be more common when patients are positive. So you may see these in your patient population. So the Cunningham panel is an aid in the diagnosis of an autoimmune encephalopathy or a basal ganglia encephalitis, meaning that it helps to make the clinical diagnosis. Because again, remember, these are symptom-based diagnoses. And so therefore, we believe and hope in the future that there will be objective biological measurements that will be standard as far as acceptance for these conditions. So the 4 assays that we look at that are targets in the brain, dopamine D1 and D2, we look for antibodies directed against these. We look for antibodies directed against lysoganglioside, GM1, which is the myelin sheath around the nerves, tubulin, which is an intracellular protein, highly concentrated in the brain, and then this CAM kinase 2 activity, in which we actually incubate the serum on human brain cells that are in a continuous culture, and we look for the stimulation of those antibodies to produce the activity of this enzyme, and I'll explain in a bit why that is important. So what we found that there are symptoms that correlate with autoantibodies against human dopamine D1 or dopamine D2 receptors. These tend to be associated with psychiatric symptoms. They correlate with mood instability, anxiety, irritability, aggression, and in some cases, psychosis. Now, there have been other symptoms that we've seen in the 13,000 patients that we've tested, and many of them can be heterogeneous, but at least when this is positive, we see these tend to be with more psychiatric symptoms. When the dopamine D2L is positive, we see that they're associated with more movement symptoms, such as choreiform movements and other types of hyperactivity. Again, motor or movement disorders. Others have sleep disturbances, behavioral aggression, et cetera. So dopamine D1 and D2 receptors, when there's antibodies directed against them, they interfere with the normal dopaminergic activity in the brain. So remember, these antibodies will cross the blood-brain barrier. They will interfere with these particular receptors, and they're through commonality of the sequences in these infections. So the third target we look at is tubulin. Tubulin has been associated when you see mutations in tubulin. You can see things like dystonia, ALS, autism. So these are published literature showing that when people have tubulin genetic defects, there's much association, or there is correlation with many types of these disorders. So when you have an antibody directed against tubulin that can interfere with tubulin, we typically see it associated with obsessive compulsive disorders, but also brain fog, what people describe as just this cloudy brain, the inability to think and concentrate, focus, and also mentioned OCD. And there are other types of behavioral associations. Now with the lysoganglioside, which is the myelin sheath around the nerve, it's a lipid that's associated with myelin. What we find is that it can be associated with tics, motor tics, vocal tics, and other complaints of joint or connective tissue pain like arthralgia. We also do see sleep disturbances, OCD, and other behavioral regression. But this particular one, we do see more association with tics and joint and connective tissue pain. So now the cell stimulatory assay that I mentioned, the calmodulin CAM kinase 2, is typically associated with sympathetic nervous system activation, meaning you'll see the fight or flight behavior, these aggression, separation, anxiety, urinary problems. And the elevated CAM kinase suggests that there's still an active infection of some kind. We find this true that either the patient may have some subclinical infection, and therefore it's important to look for these infections. There's also another company there that provides a test called ELISpot that can look at from Armin Labs these different types of active infections. But you want to be looking for, is there an active infection that's stimulating this? These are also associated with involuntary movements and the reactivation, as I mentioned, of an infection. Mydriasis, dilated pupils, again, another sympathetic nervous system activation. So because CAM kinase is involved in so many of these other receptors, and we're still doing research to understand how it is involved, that when you stimulate this, it actually impacts much and many of these other receptors. So I want to turn attention to here in the last portion is this clinical study we did and published in the Journal of Neuroimmunology. Many of these patients were tested before and after their treatment, and some of them improved and some of them did not improve. What we were looking at is what's the correlation between their symptoms being present and their anti-neuronal antibodies being present, or their symptoms being gone and their anti-neuronal antibodies being gone. So we found they had multiple infections. Many of them I have already described to you. They also had many of these different symptoms, OCD, emotional ability, sleep disturbances, aggression, tics. So in the patients who improved, this was their Cunningham panel prior to it. And so you see the 5 different tests. The heat map describes the degree of positivity and which tests were positive. All of them had 1 or more tests that were positive. In that group that actually improved by the proper treatment, this was not a treatment study, this was just correlation of antibodies with symptoms. We found that the vast majority of them either went back to baseline or dramatically improved in the number of positive tests or the degree of the positive tests. So you can see the blue indicating the number of positive tests versus those before treatment versus those that are after that did improve. Now, in the other group who did not improve, this was their panel results prior to treatment. We do see most of them having 1 or more positive tests. There is a handful of them that did not. And what we find that over time, these antibodies increase. So after treatment and after a period of time, you can see actually the antibodies begin to increase and rise. So there was a correlation between the presence and the titers of these antibodies in patients that had these neuropsychiatric and behavioral disorders. When treatment was effective, they went back to baseline. When treatment was not effective, they remained high. So it gave us an accuracy of 86%, sensitivity of 88%, and an 83% specificity. We are working on looking at treatment algorithms, but also on looking at logistic regression to weight them in a better manner. We see that when we do this, we can get the accuracy up to 90%. We're working even on other targets to improve this. I'm going to briefly cover a couple of studies. This is a 24-year-old young man who presented with OCD and tics, lost 30 pounds. He had 1 antibody or 1 target positive, which is why we run all 5. He was treated with intravenous immunoglobulin and plasmapheresis. All his symptoms resolved, and his antibodies went back to normal. Another young girl who had OCD and autism-like stimming behavior, couldn't concentrate, started bedwetting again. Dysgraphia was inability to draw, aggressiveness, relapsing, emitting, 2 positives, 1 borderline. We actually recall, I think this patient had a subclinical strep infection, and the strep was treated with azithromycin, and her symptoms rapidly improved, and after testing, they all returned back to baseline. This is another published study of an immunologist who diagnosed had a 15-year-old patient who was diagnosed for schizophrenia, but is unsuccessfully treated. She was in and out of treatment facilities. They called in the immunologist, and the immunologist ordered the panel, and the test showed that the first 4 antibodies and the CAM kinase were positive, or CAM kinase was borderline. So he treated her then with 1 plasmapheresis. The patient had complete resolution of her psychotic OCD and anxiety symptoms. She was weaned off of olanzapine, and within 2 weeks after plasmapheresis, she was resuming her normal activities and playing tennis again. So there are many other publications that I won't go into. You can look them up, or I can share them with you if you're interested on the use of the panel in different types of situations, even for patients with autism that have an autoimmune encephalitis. So briefly, I'll cover what are the therapeutic modalities that are used and what people see as far as these autoimmune encephalopathies. Well, they fall into 4 different areas. 1, as I mentioned, anti-infectives. You want to treat any underlying infection that may be clinical or subclinical. Inflammation, which is a result of the brain getting inflamed or other types of neuroinflammation. And then if that doesn't completely resolve that, then typically you'll see immune modulation and other treatments such as temporary symptomatic treatments. There are guidelines, as mentioned, PANDAS and PANS tends to be more well studied. There are treatment guidelines in the Journal of Child and Adolescent Psychopharmacology. Those were published in 2017. There's a website called PANDAS Physician Network that describes diagnosis and treatment. Again, they fall into the anti-inflammatory, anti-infective, immune modulators. You can see that there. So just a brief overview in the case of PANDAS and PANS, which again is a medical model for many of these other conditions. You want to rule out what are the other causes. You want to identify and treat all the infections and provide symptomatic relief as necessary and treat the inflammation and the immune dysfunction. With that, we do see some remarkable recoveries, as I've mentioned. And this may be just the tip of the iceberg, where neurologic Lyme, PANDAS and PANS may be an example of many others disorders, as I mentioned, even schizophrenia. This is one patient who, she was a young girl. She was asking her parents to actually kill her. They emptied out their 401k twice, and we tested her. She received proper treatment. They recently sent us a picture of her in high school that she said she's back to normal life and completely well. So here are some references that you might find interesting from a lay standpoint for PANDAS and PANS and other types of Lyme, Brain Inflamed, Brain on Fire, and a DVD that describes 4 families that have been really afflicted by this and what their plight was. So I'm going to close with this TAC law that its importance to identify the root. I adapted this from Dr. Sidney Baker, that if you're sitting on a TAC, the treatment is not 2 Advil for every 3 to 4 hours. The treatment for TAC sitting is TAC removal, and your search for the root and treat the cause rather than the symptoms. And the second TAC law is if you're sitting on 2 TACs, removing 1 TAC doesn't eliminate 50% of the symptoms, meaning you do need to treat the infection, the immune system, the inflammation as necessary. Complex conditions are complex, and to be effective, address all the underlying issues, because infection-triggered autoimmune neuropsychiatric disorders are complex, but they are treatable. And I want to thank you for listening. I want to thank AONM for their work in educating and bringing this webinar to you. And I'll end there and happy to answer any questions that you might have.
Thank you very, very much, Professor Shimasaki. That is just so moving and enlightening. Fantastic. The treatments that you mentioned, just to clarify and to ask you, it's so difficult in the UK to obtain plasmapheresis outside a clinical setting. Really only if you have Guillain-Barré syndrome or something equivalent, and IVIG is also almost impossible to obtain and very, very expensive. Do your clinicians also see success with less pharmaceutical therapies? In other words, with more plant-based, perhaps nutraceutical therapies as well?
Yes, in fact, there are a number of clinicians who do focus on that, because in some cases they don't find that certain specific types of, let's say, FDA-approved therapy is working for them. But again, if you remember that they fall into those 4 categories, is it something that will reduce inflammation? And remembering most of what we call westernized medicine is evolved a lot from natural products, even aspirin and the NSAIDs from the willow bark tree, and digitalis from the foxglove, and vincristine and blasting from the periwinkle. You can go on, and derivatives of these. Now, Someone has to understand and know that which ones work. But again, treating the inflammation, treating the infection, treating things that might calm or correct or normalize the immune system have been quite effective. Sometimes patients do require more severe therapy, or I should say, aggressive therapy. But we've also seen, just as you've described, that there are cases where these patients do respond to modalities that actually address those different categories.
Thank you. I know that in the USA, you are literally, a decade and a half ahead of us, really, with it having been discovered as a syndrome, or really, a condition there. It is so hard in the UK to get acceptance for this. In fact, at the moment, increasingly difficult, as you know. And one of the first questions here from a renowned therapist is, can you see a way forward for acceptance of this science in the UK?
Believe it or not, yes, and absolutely. We've been doing this as a company for 10 years, and it has been hard because even there are groups that just don't believe this, and sometimes they can also create difficulties in actually getting these patients tested and treated. Now, because of the history of many patients getting well and the science that has now evolved, that there is fewer and fewer resistance to that. And now with long COVID and that's showing this infection-triggered autoimmune conditions, yes. Now, what does it take? It takes a lot of patient advocacy. It takes a lot of clinicians and researchers continuing to do good research and publish their findings. It also continues the demonstration of patients getting well. And I think that in itself, those three forces over time, you kind of think of this as Helicobacter pylori and peptic ulcers, where it wasn't believed that a bacteria could cause an ulcer. And in fact, it was ridiculed, but it took, unfortunately, decades. But today, what you see is if a person has a peptic ulcer, you get a test to see if you have antibodies to Helicobacter, you get an antibiotic, and you get sent home. And I believe that this is going to happen over time for neuropsychiatric and behavioral disorders. There'll be a check, is this autoimmune or not? If it is infection-triggered and autoimmune, let's treat that first, rather than spending all of this money and time and effort and suffering on that. But yes, it will take perseverance and it will take time, but I do believe it will happen.
Thank you. I think we should probably concentrate on putting more testimonies and actual patient cases up on our website as well, as you have in the States. Another question here: if a child has 0 strep antibodies on testing over 4 years, but worsening ADHD, rage, and anxiety, what treatment would this patient need?
Yeah, so without kind of trying to diagnose anything, the idea, again, remembering that strep is one of multiple organisms that can trigger this. And this is also part of the issue. Sometimes and often it's not strep. It might be mycoplasma, it might be babesia, it might be Bartonella, it might be Lyme. And those may not have been picked up or checked or caught. And so if you don't see strep titers or you don't see strep in any orifice of the body, and yet it still looks like or appears to be an infection-triggered autoimmune condition, then one would want to look for other infections that typically are associated with these same types of conditions. And often what we'll find is that these patients have more than one infection because their immune system begins to be slightly compromised.
Thank you. Another attendee asks, is there a rising incidence of this type of condition? Have you noticed?
It certainly does appear to be. Now, whether it's because individuals now feel like they can be more open about expressing it or finding it or seeking treatment, we do see a lot. I mentioned 13,000 patients we've tested since we've opened, but we don't even have any sales or marketing staff. So This has been patients' word of mouth, been physicians telling other physicians, patients. I do believe that yes, that for some reason that there is a rising incidence, just like there's also a rising incidence of autism.
Yeah.
And whether or not there's a portion that overlaps with that is still being studied. But for some reason, yes, it does appear to be, in addition to more recognized, it appears to be somewhat of a rising incidence.
Thank you. You've mentioned that COVID-19, the virus, does appear to trigger neuropsychiatric disease of the kind that you study. Has it been found yet that the COVID-19 vaccine also triggers neuropsychiatric disease?
So again, without another hour to talk through all of this, as I showed you, molecular mimicry does occur between different organisms, and whether it's a portion of the organism through a vaccine, or whether it's the real infection, in the context of patients that have genetic susceptibility to non-self dysregulation, there has been some recognition that you can have different types of these autoantibodies triggered. So if you look at myocarditis, which is an autoimmune direction against the myosin and the muscle proteins, you do see that in certain patients, a very, very small number of patients that have been vaccinated. But you see it in a larger percentage of patients who have actually gotten infected. So again, it's the percentage is higher in those that actually get the infection. But it's to say that molecular mimicry in the context of an individual that has a genetic immune sensitivity to that can occur. You can also look at autoimmune conditions that are the sleep disturbances and things like that with influenza vaccination. So it's not so much that it's just the vaccination, but it's in the context also of individuals that have a genetic susceptibility.
Thank you, that's fascinating. One question here relating to foodstuffs. Is it possible that cereal grains can have an effect on the neurology or psychology of patients? I know this isn't directly something you study, but within the overall context of therapy, you probably do also know that certain therapists take a nutritional approach as well.
Right. So again, remembering we're talking about an immune-mediated response. So anything that actually triggers the immune system to have, let's say, a heightened or an oversensitive response, such as celiac disease, other types of sensitivity to gluten's, things like that. There has been evidence in patients that when they actually deal with those food sensitivities, that some of these symptoms will greatly improve. Now, whether or not it completely eliminates the condition, we don't know for sure. But again, remembering that this is an underlying autoimmune condition, an immune-mediated trigger, that things that actually stimulate or increase the heightened immune response, if you can reduce those and you can eliminate those, generally they do see patients doing better and having symptom improvement.
That makes sense. Thank you. Do the medications or herbs used need to cross the blood-brain barrier and access the brain in order to have an effect?
I probably can't generally answer that statement other than saying, because you're trying to treat multiple components. One of it is an infection, which most of these infections in these kind of patients, you don't see them in the brain. So you're treating the infection. The anti-inflammatory and immune modulatory pieces, yes, you probably would, because you see this microglial activation, you see these antibodies that cross the blood-brain barrier. But there is one other part that is this leaky blood-brain barrier. So if the blood-brain barrier in these cases is not permeable as much, then you can also see that the ability for these antibodies to cross into the brain get reduced. And there's evidence for that in the case of lupus, where you look at the progression of these autoantibodies in the serum that then translate to ultimately crossing the blood-brain barrier, and then they get diagnosed with full-blown lupus. So I would say it depends. That's probably the best answer.
Yes, no, there are quite a few questions coming in on therapy, and we do need to say that because this is more a webinar focused on the testing aspect, as well as, of course, the entire etiology, we will need to have another, I think, webinar on therapy with you, of course, Professor Shimasaki, and perhaps with, I know we've discussed this before, with perhaps with Dr. Yanuk as well. So even though that's been difficult over the pandemic, I'm sure we can organize that in the next few months. One of our doctors here is asking, thinking of the TAC rules, multiple infections are common, particularly coexistence of bacterial infection and Candida albicans, this often being subclinical until antibiotics are used. Can you suggest a stepwise strategy for management of PANS in a typical case?
Yes, and in fact, the treatment guidelines actually address it in a stepwise manner. And so you're looking at the early stage first to identify, well, first of all, they want to rule out any other condition. The second is then you want to look for, are there any infections? Because remember, this is an antibody-mediated stimulus, and the infections are the stimulus, at least in these cases for PANDAS and PANS. So you want to look for those and then eliminate those. And as was shown in one of those case studies, the simple, in that case, the use of azithromycin actually resolved that girl's symptoms because the strep was the actual root. And it was early enough that the immune system wasn't, let's say, well entrenched, such that that didn't actually ameliorate the symptoms. So identify the infections and multiple infections, treat them. If that doesn't completely eliminate, but it does reduce it, typically what they have in those treatment guidelines is you move to anti-inflammatory agents. And some of them are even as simple as NSAIDs, for the over-the-counter NSAIDs to see if you get resolution, up to things like prednisone. So again, these are guidelines that they've well published. If that completely ameliorates the symptoms, you don't move on. If it almost gets them well or they relapse, then they move over into these immunotherapies. And then, of course, if it still doesn't completely resolve 100%, they could move into the more aggressive ones.
Thank you. Just a couple more questions. I know we're running over the hour now. One attendee asks here, you've mentioned giving steroids, and they appear to be in the guidelines too, but these of course suppress the immune system. Could they possibly allow viruses and bacteria to continue proliferating, unnoticed perhaps, and then worsening symptoms?
Certainly, it is one of the side effects of suppressing the immune system. And this is also the need for better therapies, which kind of occurs as you see with SARS-CoV-2. You have to first get a vaccine, then you work on treatments and therapies after you got tests. What we see here is that, yes, steroids can and do ultimately long-term suppress the immune system, but what they call is steroid bursts. Typically, they will use them at certain doses to quench the symptoms or calm the symptoms, and in that case, see whether or not that resolves it. They're not generally talking about in these guidelines long-term therapy like you would see maybe in lupus patients and other patients. But yes, that's always a condition that you want to monitor. But they do find some very effective treatment with what they'll call steroid bursts, and that's also in the treatment guidelines.
Thank you. Most of the other questions that have come in are either relating to therapy or to specific cases where the attendees are, of course, looking for solutions. So we will save all of these questions for the next time we have a call with you and perhaps with a clinician. Mm-hmm. Could I just ask, please, because one attendee here who I think may have joined late is saying, are specific labs being utilized? Are they accessible from the UK? Just to mention again that, yes, this is the lab that is used and is really unique in the world. I mean, there is no other laboratory worldwide that does this testing. It's called Molecular Labs, I'll pronounce that again, Molecular Laboratories in Oklahoma, and the hub for that is, or the liaison for that is the Academy of Nutritional Medicine. It's the Academy holding this webinar. So if you're interested in exploring more about perhaps doing the test, please do go to our website, that's aonm.org, and there is a tab there called PANS PANDAS, which has a lot of information about the test, and also the helpline number is there. And just give us a call and we'll explain everything about it. And AONM sets up the entire process for you, including the courier collection, and ensures that the sample gets to the States swiftly. And the turnaround time is surprisingly fast, isn't it, really, a lot of the time? I know we have
faster compared to used to be 6 to 8 weeks because of the complexity, but we're improving all of the processes.
I'm hugely impressed. Thank you. So just to say thank you very, very much again, Professor Shimasaki. That was really stunning information. And people are asking whether it will be made available afterwards. Yes, this recording will be put up on the website. It'll be available beginning of next week. And it'll be under recent webinars or past webinars, I think it is, on the AONM website, and also on the PANS PANDAS webinars section of the website. And just to mention that we are having another webinar in July, on Tuesday, the 12th of July at 7 o'clock again. That is with Dr. Eva Schappi, a geneticist from the US, who will be talking about the potential connection of Borrelia infection and breast cancer. So that's going to be very interesting indeed. And so can't thank you enough, Professor Shimasaki. Thank you. And thank you to everybody who attended today, and also everybody who'll be watching the recording. And please just contact us, and we can always contact Professor Shimasaki if there are questions beyond what we can respond to. So any final words from you, Professor?
We appreciate the relationship with AONM, and that, yes, please contact your organization, and help is there. We'll also do what we can to help, but we believe that this is how medicine changes, and how the practice of medicine will change for patients and physicians who treat and take care of patients with these neuropsychiatric and behavioral disorders. So thank you for your educational work, for all the other work that you do, for collecting specimens and helping getting patients tested and treated.
Thank you very, very much. We are looking forward to having you here in person, hopefully very, very soon.
Yes, I'll look forward to that too.
Thank you.
Okay. Bye-bye.